Dr. Wei Hwa Tan from Taiwan he will present the last interesting case, preemptive intervention for the promoting early foul lumen thrombosis. Sorry, sir.
Okay, I thought I can escape from my talk. Okay, so I'm the last one to present the case. So in my talk, I think I present more cases on how to do with the distal entry tear. So a little bit different with the previous speaker. I'm Dr. Jimmy Tan from Taiwan. I'm a cardiovascular surgeon. I have no conflict of interest for my presentation. So I came with the first case, 56 years old. The patient has hypertension, diabetes, syncope with the left side weakness on the 2021. And then we have an emergent operation for this patient. And actually, during the same admission, we do the zone 3 T-bar because the patient has a compromised true lumen. The reason that we did not do the T-bar at the emergent operation because for all our patients, if we don't noted any tear over the arch, we won't do T-bar. So in the same procedures. So you can see here that the patient has significant and compressed true lumen and intractable hypertension. So we put a stent to ease the problem. So 1 year later, the patient suffered from an episode of frontal cerebral stroke. And also he has some malperfusion symptoms. So we look back the CT scan for this patient. And then we found that eventually the patient had a distal arch growth to 6.9 centimeters. And we plan to do the re-intervention for this patient. So you can see here we have a enlarged distal arch, 19 months post type A repair. And we think that the tears and the flow come from the tear over the graft aorta anastomosis and causing the malperfusion. So the plan for this operation is that we do the double chimney T-bar with the zone 5 extension T-bar and left renal chimney to close the distal tear, and also the arch false lumen TAE for this patient. So the reason that we do the arch TAE for this patient because we found that the supra aortic trunk of the patient was also supplied by the false lumen, and maybe will cause the future dilatation of the false lumen. So not just treating these true lumen, we'd also try to do the obliteration of the false lumen. So for this patient, we do the percutaneous puncture of the carotid artery because in appropriate patient, we do the percutaneous technique for chimney. We don't open the vessel. So also we do the paragraph in this way because we want to minimize the gutter. So minimize the gutter leak for the patient. So after we do the double chimney T-bar, we'd also look at the flow at the false lumen, and we found that there's still flow from the carotid. So we do the TAE over the false lumen part. So at the thoracoabdominal level, we tend to close the tear from the left renal artery intima tear using the B graft, the balloon extendable stent graft. And this is the picture that 23 months later after type A repair, that we have a strain gauge of the distal arch. So from this case, okay. So I think TVAR is the class 1 recommendation for complicated type B, and also the class 2A for uncomplicated type B. So we are becoming more aggressive in treating this kind of disease. So I think the primary goal using TVAR is to close the primary tear, as you heard from all the speakers previously. And also we want to achieve total thrombosis of the false lumen, because a partial thrombosis could cause a lot of problem in the future. I think the most important issue is that a lot of patients, when you treat it medically, 65% of reintervention were due to the aneurysmal degeneration. So, and the duration for the reoperation is only 2.3 years. So it means that the outcome for medical treatment is not as good as we think. And also with the optimal medical treatment and TVAR, we can have a better aortic specific mortality and lower progression, and also complete the false lumen thrombosis. This is the important issue that why we want to be aggressive. So how about we preemptive false lumen intervention for our patient? So I show you one case. This is a 46 years old TSMC senior engineer suffer from acute type B dissection. He sent to my hospital, and I also received a hemiartery replacement with AVR because the patient has bicuspid aortic valve with severe AR. And with follow-up CTA, we show that there is still residual type B as usual with a AAA, not big enough, but just still AAA. After this operation during the 3 months post-op CTA's follow-up. And as you know, the TSMC is the largest semiconductor company in the region. So they always work hard and very important to the company. So the patient said he want a complete repair. Okay, so this is a picture of this first type A occur when we treated with open surgery. And then after the surgery, we can find the quite good remodeling of the thoracic level of aorta. But the thoracoabdominal level, we still have aneurysmal change of the infrarenal AAA and also the right common iliac artery aneurysm. So for these two problems, I think we can do preemptive early. This is their revenue, okay? the Q1, so that's a very big company. So that's why he needs to have a good, healthy body. So this is how we treat it. We want to try to obliterate all the distal tear for him. So also we want to protect this visceral vessel. So for this patient, we try to reroute the electron back to the true lumen with the stent graft, and we close the true lumen, false lumen with some coil, and then we also redirect the left renal artery back to the true lumen, and then we still find let's go back and see properly. So okay, actually after we do the coil, so we still find that there's a backflow from the left common iliac artery interior. So in this case, after we do this intima tear closure, we also perform the early EVAR for him. Okay, so in order to close all the tears. So this is how we do it. We use the endo-adherent 2S, and then with those Chinese stent and also coiling. And this is the picture we get 22 months later after the procedures. You can see the complete remodeling of his thoracoabdominal dissected aorta. So there's no further deterioration or distal break or other problem after we do early preemptive intervention. So this is currently in my institute that we look at how we look at intimate tears. So this is very important for us because we want to do a proper document of how we treated the entry tears. So we can say that we divided this situation into complicated, uncomplicated, and uncomplicated with high risk, and we heard those high risk factors from previous speakers. So looking at the results, so if you can look at the result, actually, if you do the early TVAR, you will have less aortic reintervention from the virtual study at 3 years. So if you do it at the acute phase or the subacute phase, it seems that you will have less reintervention. So you also have better remodeling of aorta after acute TVAR. So this is also very important for us because currently we are not just going for treating the problem, but we want to solve the problem. And also from the IRIS study, after 5 years, you can see that we have a quite promising result from the endovascular group. And also this is another study treating the acute uncomplicated type B dissections, where for the TVAR group, there's two significance. One is that they have a lesser aortic-related event more than 30 days, and they have a lesser mortality rate more than 30 days. So this is very important if you really want to put your patient for the acute uncomplicated type B dissection, early TVAR. So for me, I think this mnemonics dissect is very important for me because I can use this to evaluate the patient before I put him into the TVAR operation. So finally, we come to the final case. This is a residual thoracoabdominal dissecting aortic aneurysm. 62 years old patient with a type 2 DM and hypertension, CAD with angioplasty before. It's presented with chest pain on the 2018. And then the patient has a type B arch, PAU, IMH, and also thoracoabdominal dissecting aortic aneurysm. So firstly, we do the zone 2 TVAR for this patient because I think the proper proximal landing zone is very important to do these complex procedures. So this is the CT. We can see slowly about how it looks. You can see it's quite complicated for this patient, especially over the distal thoracic and thoracoabdominal level of the aorta. And he has a very big intimate tear at the middle of the distal thoracic aorta and very compromised. You can see the perfusion here. You can see we put our catheter in true lumen. So it's a very malperfusion status initially. So we use the IVUS to make sure that we are in the true lumen, and we use the stent to TVAR stent to treat the arch and the proximal thoracic aorta. So this is the picture that after we do the first intervention for this patient. So eventually we found that the true lumen was open after the initial TVAR procedure. So we are satisfied with the result. So we did not go on because doing too long standing in one procedure will cause the risk of paraplegia. So we left the patient. But 3 years later, the patient suffered from 2 episodes of GI bleeding. And they find that it's a duodenal ulcer. And the GI men, they are very reluctant to treat the patient because they found the patient have an enlarged abdominal aneurysm. And I will show you later. And anyway, because I promised that I will cover them, so they went into treating the patient with a hemoclip and failed at the second time. So they consult the radiologist for the TAE of this GDA vessel. And then you can find that the aneurysm has grown large. So this is the IR specially treating this GI bleeding using the TAE. And this is another problem is for us that the patient eventually there's aneurysm grow to 9 centimeters. So this is a large, little bit complicated dissected thoracoabdominal aneurysm. So for this patient, my plan is to use the endovascular way to treat it because it just had a GI bleeding episode, unsuitable for surgery. And I think very importantly, I have to close all the false lumen. So this is one of the channel I can find. So after checking this flow, I use a coil to coil this part of the false lumen. And then for the true lumen, we use the Gore stent graft because we're afraid about the suprarenal stent might cause other new intimate tear. So we only use this Gore for this patient. And initially we noticed some endo leak from the type 1A, and then we use a cuff extension to solve it. So after 14 months later, you can see the aneurysm shrinkage. And eventually we see no flow in the false lumen. And I show you the comparison of these two studies, the same patient in the 2 periods initially and finally. So we can see there's a quite good results after we do this intervention 40 months later after the primary intervention. So I think currently the strategy dealing with complicated type B dissection in our institute, for acute patient, we do sealing proximal entry tear. And for some patients, we use pedicle and revascularize the visceral vessel if remain compromised after the primary tear coverage. And we sometimes need balloon fenestration for very difficult cases. And for the chronic cases, I think very important issue is the additional coverage of distal entry for promotion of a total false lumen thrombosis is our technique. And you can see here, although we know that the TVAR had more reintervention rate, but from this study, we find that actually those reintervention rate doesn't have a very negative effect on the overall survival. So although we have more reintervention, but I think we can still do it under a quite low mobility rate. Like here, you can see 0 30-day mortality, 2% stroke, and 2% paralysis, and 4% hemodialysis. So I think early TVAR for uncomplicated type B dissection is very justified, especially for the high-risk patient. And I think we have a 90% false lumen thrombosis at 5 years. So I think one issue is very important is initially avoid aggressive oversizing of the arch, and also avoid TVAR in patients with a very large ascending aorta or arch aorta. And I think surveillance program is very important because we sometimes need to treat the residual thoracoabdominal dissections, especially those with only partial thrombosis, which will come back very early sometimes. So I think summary from my talk, I think benefits from promoting false lumen thrombosis and aorta remodeling seems only better in the thoracic aortic level with stent graft. So you need to treat it, not just one-shot procedure. Maybe reintervention rate is high, but the outcome doesn't, the cumulative survival doesn't lower due to the reintervention. And I think adjunct procedures like TAE or distal tear closure, I think is promising for promoting early thrombosis. So I think this could be one of the way to treat this kind of patient. Thank you for your attention.
So, thank you so much, Professor Chen. Very nice presentation. So,
Thank you.
So even China Pong, I suppose, Professor Bong and Dr. Pong, so we do agree with your opinions. So we do agree with your opinions, never net acute of that second term to be chronic. That's the first one. The second one, that you deploy the microcoat inside to the false lumen. It's also a very good method. So in China, we have deployed the occluder.
Yes.
So, in Korea, even some doctors would like to deploy lots of microcoats inside the whole false lumen. So it's a very good result. So also the first case you show us, so we may find it's a fantastic case.
Sure.
So we emphasize this case. In fact, the whole aortic arch is very weak. So that's why it will keep enlarge of the TVAR. So in such kind of situation, usually in full-line hospital, if the patient condition is very stable, we will avoid the first 2 weeks treatment by TVAR. We're waiting for about 2 weeks, then we perform the TVAR. Even we deploy the stent graft to be a little forward, especially to some cases it's a long A, long B. So it's very important. Thank you so much. Very nice. Very nice. Thank you.
Yeah, sure. Dr. Budisit.
Yeah, well, thank you very much. Nice talk as always. Very informative. My question is, can you explain a little bit more about the coils in false lumen? Two issues. One is where you put the coils, because sometimes false lumen is so big. Number two, if the branch is from the false lumen, I saw that you put a stent. What if there is no re-entry close to that branch? How can we get from the true to the false and put a stent in there?
If we do the case early for these cases, actually it's not difficult to find the tear. I think the only problem that you can't find the tear, or there's a tear but the tear is not big enough, is in the chronic cases. So for those kind of cases, sometimes you might need to sacrifice some vessel. So some cases, in my experience, sometimes we need to sacrifice ciliate trunk in order to get a better, early false lumen thrombosis. But it's okay because you can check the SMA flow to check whether there's a collateral to the, ciliate trunk area. So it's quite safe, I think, in my practice. And how to do the deployment of the coil actually is not difficult because for me, I only try to occlude the outflow and the inflow. So there's only 2 parts you need to coil. I don't like to put all the coil in the false lumen, like throwing the garbage in, the false lumen. So I only try to occlude the inflow and also the outflow. So I think these two parts is good enough. So when you do that, and when you do this angio and you find that the flow slow down very quickly, then you know that you might be very success. So we only use the we only use a cleansing plug, or we use some excluder if we have a very large false lumen in those cases. And but I still think it's very important that before you put that large candy plug into the false lumen, you have to be careful, because if you fail to occlude by the candy plug, it will be very difficult for you to do the second intervention. And also there's one problem is that if you do the candy plug, you better have an apposition T-bar with the candy plug, or the candy plug might break your intima tear in the future. It's my experience. So if I use the candy plug, I would definitely put another T-bar for better apposition to avoid future rupture of these in the intima, the old intima. Yeah, that's my strategy. Thank you.
So I think it's time. Yeah, real time for the break. Okay, thank you every speaker and moderator and everyone that joined the meeting. Dr. Brunpasit, อาจารย์มี last word for the audience and the participant.
Yes, well, thank you very much. All the speakers, panels, and audience to join this year aortic master. I would like to thank Medtronic for the support. We are hunger for this because of the COVID. We don't have a chance to get together, particularly for the international kind of meeting like this. So thank you very much for coming, and hopefully we have discussed and shared and will be beneficial for our practice to help our patient. Everything we do, everything we discuss, I'm sure that we have our patients as centers. So we do the same thing, do the best thing for our patients. And hopefully in the near future, we will be able to come back again. I don't know where, maybe in China, maybe in Taiwan, maybe in Vietnam or Malaysia, somewhere. And hopefully the Medtronic will continue to support us and get together and do the best thing together. So we are partners. We grow, we do good thing, we grow together. If we do bad, we will go bad together, I guess. But we are sure that we will do good, do best, excellent for our patients. So thank you very much. Have a safe trip back home, everyone. Thank you.
ขอบคุณค่ะ ขอบคุณ Thank you everyone again ค่ะ ขอบคุณนะคะ